check-in, the whole course check-in and underlying understanding the learning platform. People so far have been able to check into the platform, and they have been able to also they have been able to go through the quiz and all the requirements. So, but the first task for everyone we expect is to complete the introduction in the course forum, or what we have called Mentees Cafe, to be able to get to meet other people from other maybe geopolitical zone in Nigeria, for those who are in Nigeria, and also for those who are outside Nigeria, to get a sense of where people work, their background, so that then helps in interaction, and also when we want to do teamwork, to know who do we pair with the next person and all of that. So that was very important, and we've been able to go through that. Another important task for week 1 was also the pre-course quiz, which I believe by now majority of people have, to a large extent, completed that. We also had a presentation about the purpose and the outcome of the Development Nutrition Academy course, and that was made available in the course platform in form of voiceover PowerPoint presentation for people to know. There is actually also like a slide on course core value, which gives like a summary of the participants who have applied. There are a lot of information about them, gender, whether or not they've had training experience in program implementation, and all that, just to get a sense of this is where people are coming, this is their background, this is the level of experience they have, and all of that. So that was also a very important part of the course that we have done. Of course, we also had a case study on the Rwanda nutrition situation, and there were also quiz questions that are related to that. We also participated in the module 1 introduction, which looked at the case study of the Rwanda, and try to discuss it and to bring it into life more like. Okay. Also, we looked at participants' expectation. This was in a way introduced under the nutrition workforce module, where people were asked questions relating to what they would like to learn from the course, and what are their overall expectation at the end of the course. Okay, we also have about mentors. We also have about mentors that we have really not explored, but rather we prioritize more the interaction with the Meet the Development practitioner, which I will talk about later. So at least for that particular stretch of first, we did quite well in that. The issue of time management, adapting learning to case method, and all that was captured in the welcome notes that try to encourage people on how to manage time and all of that. What we've really not been doing well is the learning reflection. I want to believe that individually people are reflecting on what additional new insights they are gaining as a result of resources they have access to in the course, and also maybe from interacting with their fellow coursemates. Okay, so far with that, we've been able to make progress. I will go over again to see. We also did go over overview of nutrition programs in Africa. We did discussion forum regarding that. We attend the participant case method, but we've not received it back. But I want to believe by now individuals have completed the case method and they've started to discuss with their mentors on their design approach or their project ideas and other issues relating to what they would like to work on. There were also resources on short video that was part of the overview of nutrition program, also made available. And of course, there was a YouTube link to the Meet Development Practitioner, which was an interview with Dr. Francis Aminu. The Meet the Mentors, where all the mentors for the courses are supposed to check in. We are putting that on hold at the moment because we are trying to look at the cadre of mentors. A lot of the mentors were senior people, so we're trying to see what would be the best use of their time, so that we don't give them the task of logging in. But I think at a point eventually they will have to be granted access to the learning platform for whatever it is, even for them to understand the whole course structure, what course participants have been learning, and perhaps they may have input. We also plan to have a collaborate session where we can see, maybe not all of the time, but certain time, like a summary of the engagement between the course participants and their mentors. So with that, I can also say we made some progress. The other schedule for participant case method updates were really individual assignments, which I believe, as I said, that people have been able to do. So where we are at the moment is now what led us to today's webinar, which is the Introduction to Nutrition Program Design. So the reason why we're opting for live meeting for this is because it's also like our first active interaction, even though we've tried to make it self-paced so that people can go at their pace. But it's also important for us to have live interactions where we're then able to do. So following that, we'll go in depth into the logic model, which would be, in this case, maybe module 5. We try to put it under module 4, but it looks like too much information per time, especially for those who are new to program or project management and all of that. Of course, there's meant to be course evaluation and all of that. And whatever the learning from the project design is, the next step will be for course participants to then update their project idea, which they have articulated in the case method, and then begin to define goals, objectives, their result framework, and how that will be monitored or tracked throughout the course of the project. So I guess that's the schedule we have, just to give a background to the progress we've been able to make. Well, I will not go into individual progress in terms of who has done what. I believe every one of us know the stage we are at this moment. So, Introduction to Nutrition Program Design. And I was beginning to talk about why it is important to really make an attempt to design nutrition program. Because for a lot of people, they just, think the next thing we need to do is training, or the next thing we need to do is just, go to the field or distribute this item. So it's important to put in a design in nutrition, because we cannot use a one-size-fits-all approach to address all nutrition problems, because the causes of malnutrition is different, is diverse, and so the approach for addressing it also needs to be different. Also, preventive nutrition program approach such as maybe vitamin A supplementation, let's say agri or food distribution or food system approaches. Adopt a population-based strategy to address malnutrition and its consequences. And it is often very important during the developmental window of opportunities, such as the first 1,000 days of life. So, and during adolescence. So if a woman is pregnant, from the day she's pregnant, there are requirements that she needs to go through. So we need to know, okay, what category of women do I need to target, or group of women am I targeting? So on that population level, it's important to have a design that segments the target audience, that looks at different parameters around a particular geographical area or whatever we seek to work. Essential nutrition actions is a life cycle approach, and it requires adequate planning. Also, because of a lot of emergency situation, conflict situation that are going on in the world, we are having to increasingly implement recuperative intervention when it is required, especially during emergency situations. So what are the steps in the design of nutrition program? The first step primarily is to be able to define the problem. What problems are we trying to solve that warrants that we have to implement a nutrition program? And the best way to do that is by assessing the nutrition situation, either through collecting anthropometric data or reviewing existing data sources. We can also assess infant and young child feeding practices or review available data on IYCF. We can assess maternal nutrition or review available data on maternal nutrition. We can also review data on micronutrient status of children and women. We can review data on underlying disease burden. And also, once we do that, the whole idea is to identify and be able to, define the possible causes of malnutrition. So we may also need to dig deeper to understand beyond all of these, statistics or data we may have, what other factor within the community or practices are influencing these outcomes. And once we do that, we have to determine what program focus do we want to adopt. Are we adopting a preventive approach, or are we focusing on a recuperative approach, or are we going to go the way of the combination of both preventive approach or recuperative approach? Overall, the outcome from this stage is to be able to have an indication of a priority interventions to address malnutrition, especially among women and children and perhaps other vulnerable members of the target geography. So that's the broader picture for that particular step. But now, breaking it down, how do I, go through collecting all of this data? And one of the first steps to do is to gather quantitative data. So we may gather quantitative data on to identify or to define what we are looking for. So we can define indicators for our specific program of interest or whatever we perceive, because oftentimes we will have perceived a certain problem that we may be interested in. So we have to look at, so for this problem that I am maybe guessing, it's just like you are doing a diagnosis of a disease in the hospital. So you go with, I feel like I have a symptom of malaria or something. So based on that, you are likely going to do an investigation around that area. Maybe you do a malaria parasite test or whatever. So in the case of nutrition too, you probably have like a guesstimate. Yeah, I guess that's the word I'm looking for. A guesstimate of what you perceive or what your team perceive as a nutrition problem. So the best way to go about that is to then look for relevant indicators that may be required for decision making. For instance, you may want to know the stunting data, the wasting, underweight data, infant and young child feeding data, micronutrients deficiency data or maybe coverage data on micronutrients. So once that indicator is clearly defined, then you go ahead to identify data sources. And these data sources may include oftentimes the demographic and health surveys. They are always very useful and reliable sources of data, which is usually a first go-to when you are trying to design your nutrition program. You can also look at the multiple indicator cluster survey, that's the mixed survey. You may look at knowledge, attitude, and practice data where it is available. And you can also look at other data sources, including the Ministry of Health, Health Management Information System. The challenge with Health Management Information System is that it may not present the complete picture of the nutrition situation, since data may only be available for those who use the public health system. So that's like the drawback in using that particular source. So automatically it will exclude the non-users of public health system. It may even exclude the private health system users, because in some contexts the private health system don't necessarily report to the public system of the public health system. So that may be the drawback in using health management information system. Also, other sources like local surveys that are conducted by other organizations, including UN, NGOs, research institutions, and donor organizations can be used. When you are examining this data, you want to check for the availability of disaggregated data, such as sex disaggregated data, sex economic status, and this information is useful to understand who is most affected. So you want to know who is affected by this particular set of challenge or all of that. Also, you want to collect data on trend in nutrition status and program effectiveness to determine the change over time. So you can do a trend of maybe data from 2003 to 2018 if you have those level of DHS available in your country. You also may want to conduct baseline survey to gather your quantitative data. Okay. The next is to gather qualitative data. Qualitative data are useful for understanding cultural norms, belief system, and practices that exist in a target area or target geography, if you like. And usually for nutrition, you may want to collect information about food consumption practices. Like you may collect data on commonly consumed food groups in a community. You want to know the availability of food in local markets. You want to know how accessible this food is to those who are most vulnerable, especially those in the low socioeconomic status group. You also may need data on the available health or nutrition or agricultural services. For instance, you may want to know the distance between health facility and where people live. You may want to assess what are the barriers to receiving service. Is transportation available for people to move from their houses to the health facility, for instance, if it's an health intervention? If it's an agri intervention, for instance, if you want household, maybe family household, to consume more of what they are planting, are there agri extension services that is able to reach them? And are these agri extension workers vast in nutrition knowledge to be able to, so available nutrition agricultural services, including the distance to service. And also you want to assess the community perception about the quality of services. Also, you also want to collect information around community structures, the social dynamics in a community, the power relation between maybe men and women, what is the control of assets like, who controls access? Do women have access to resources like land ownership and things like that? You also want to assess the cultural beliefs and practices. What is the livelihood source of the people and pattern? How do they get income? How do they get access to food? Do they plant it? Do they buy it in the market? And all of that. You also want to collect information about the vulnerable group. Where are they located? Which group is more affected? Are there ethnicity issues? Are there marginalization of certain sector of the community? And all that. You may also gather information around the available policies and guidelines, nutrition relevant guidelines, or something that is related to your program. If you are doing gender related activity, you want to look at the gender policy of your country or your region. If there are specific strategy you want to look at. For instance, if you are working on infant and young child feeding, you want to look at the infant and young child feeding guideline. Or if you're working on agri-sector intervention, you really want to look at the agri-sector nutrition strategy where it exists. Overall, you want to start with the National Policy on Food and Nutrition policy in your country and to look at what intervention are allowed, which ones are not allowed, what procedures or guidelines are put in place for implementing such interventions. Okay. The sources of this qualitative data that I've mentioned include recent data from published reports, like maybe you can have from academic and research institutes, maybe data on food consumption data. These are data that are not easy to, you cannot quickly conduct a food and food consumption survey. This is the type of survey that takes time to, this is the type of information, it takes time, to be able to conduct that. So you want to rely as much as possible on published reports. Also, you can get data from NGOs, from private institutions. You can also still use DHS data, like we have said. For instance, the DHS collects qualitative information around infant and young child feeding, what type of food people are eating, and this can be useful resources. There are also local surveys and reports that can provide you some of this information. Other sources of qualitative data may be when you collect data on field-based data. And field-based data may include focus group discussions, like structured discussion in small groups to obtain information about perception of common practices, the beliefs, and the concerns in the community. You may also want to conduct key informant interview, and key informant interview is an in-depth talk with knowledgeable individuals. For instance, you may have the community leader, NGO staff, health clinic staff, maybe a lead extension officer who can provide you information about the community that you would otherwise not see in surveys. You can also do direct observations of practices such as hand washing, antenatal. You can look at antenatal care nutrition message. You can maybe go to an antenatal care session and really go there to listen to what the health worker is thinking or is presenting to the people to see whether it includes nutrition content, for instance. So you don't even have to announce that you are doing observation. You are just checking firsthand what content the health worker is teaching pregnant women, for instance. So you can do direct observation. You can also do participatory rural appraiser or participatory rapid appraisal, what we call RRA or PRA. And the RRA, the rural rapid appraiser, is usually conducted over a period of about, you can use field-based qualitative data collection to gather your data. So it can be through focus group discussion, which are like discussion in small group. Usually ideal focus group should not be more than 6 to 8 persons, but in some instances you may see large focus group which are about 15, but 12 to 15 participants. But ideally, focus group discussion should be small group where you can obtain information about the perception of maybe certain food. So in some communities, they may say a pregnant woman cannot eat snail, or children don't eat egg. These are beliefs, that may affect the nutrition status of people in the community. So you want to really find out what is the perception of people regarding children eating egg, for instance. What are the perception of people regarding pregnant women not eating snail? So you try to uncover some of these behavioral practices so that these then inform how you design your maybe social behavioral change intervention. But we are still at the level of, you are trying to design a project, you want to gather data on what is the nutrition status of this community and what are the practices that may be influencing that. You can also do that by conducting key informant interview, where you have in-depth talk with a knowledgeable individual like community leader, like I said earlier, NGO staff, health clinic staff, agric extension workers. You can also do direct observation of practices, like do people wash their hands before they eat? So people can fill a questionnaire and you say, do you wash your hands? And everybody click yes, yes, yes. So you come to a 90% of people in the community wash their hands before eating. Fine, a good source of data. But you also want to observe in the real life setting when nobody is watching them, where you just sit as a community observer. Do people really wash their hands when they are eating? So you may go to, say, a naming ceremony, for instance, or a wedding ceremony, or a burial party, and you are looking at everybody that was served food. What were their reactions? Do they think about using a sanitizer if there's no water? Or do they maintain certain hygiene practices? And then you can begin to then merge what the qualitative data says or what you have been able to observe to, it can even be a qualitative data source during the interview because of observer bias or social desirability bias, if I remember correctly. It can be social behavior, in bias, where people that know research on the understand this. There's what we call social desirability bias, where when you ask me a question, I tend to present what I feel you like to hear. So if you ask a mother, for instance, if you ask a mother, do you exclusively breastfeed your child? That would not be a good question to ask though. Do you exclusively, the person will say yes, but maybe the ideal way to ask question is, oh, when you breastfeed your child, what other things do you give your child? So these are the difference between the expertise in collecting qualitative data. Because if you ask somebody, oh, do you do exclusive breastfeeding? That is even not a good qualitative question, because a qualitative question is not supposed to be a yes and no answer. It's supposed to be what people will open up to discuss, actual talking, not a checklist type of thing. Okay, so these are some of the things. So this multiple level of data source will help you to do an assessment of the real situation of the practices that may exist. So I started to also talk about the rapid rural appraiser or the participatory rapid appraiser. Well, people sometimes use these two interchangeably, but they are slightly different. The rapid rural appraiser, they are like discrete type of information that you can collect for about a week when you enter into a community. You engage people, collect data, and all of that. And the purpose of rapid rural appraiser is to collect program design. Huh? Okay. So, okay. And so you can also do dialogue, community dialogue, to also understand some of the issues as part of the rapid rural appraiser. And one of the good examples I would like to say about that, I remember it's been some years, really, maybe 2009, if I'm correct, between 2008 and 2009, when we were doing an assessment of how to reach communities in Osun State. Osun State is in southwest Nigeria. And one of the things we wanted to do then was to understand some of the barriers affecting the coverage of vitamin A supplementation. So we did get that, well, some health facilities were too far away from the communities, so health workers don't like to go to those communities because the transport cost is high, government will not pay them transport. So we did a mapping of these communities in Osun State, about 599 communities more. And I can tell you, most of these communities were really hard to reach. But there was a particular instance where there's an health facility in a community. The health facility was just about 1 kilometer to where most of the people live. But these community members will not use this health facility, but rather they would go to another primary health care facility that was about 15 kilometers away. So we didn't understand why that was the case. Why would we provide, supply trained health worker in this facility and you don't know? Anyway, through community dialogue, we were able to uncover that the health worker in that particular health facility or PHC that is close to the people is from another community that has conflict. So it's like a border community that has conflict with this other community. For people who may know, there's a Modakeke Ife crisis, right? And that has endured in a particular ethnic group. So in this community, the health worker will say, I cannot give this particular health worker who is from this other ethnic community to supplement my child with vitamin A. So they would rather go 15 kilometers. So there's no way you can find this kind of information in a quantitative survey or DHS and all of that. So which is why it's important to engage in some of this. And if we don't do this kind of detailed design and assessment at the level of your design, you find out that it's likely that the program may fail because you then go ahead, you invest money in training health worker in this health facility that people will not go to, you supply, vaccine or whatever, vitamin A supplementation, buy scissors, wipes, or whatever logistics are needed, and you realize that the coverage still remains low because people will not access it because of this factor that, if not addressed, it will continue to hamper the program and all of that. So the participatory rural appraiser is also an extension of that. So that the issue with this one is that it can extend up to 6 months to a year, and the purpose is often beyond gathering data, is more to promote community ownership of an idea. So you want a community to engage in the process of design. So you want to make sure they are using it. And I also always have a good example. So during my course of study as a student, I heard this beautiful story that stuck with me during a monitoring and evaluation course. I think I did as part of MBA. And the professor who taught us then said there was a particular community. I think a politician or somebody, had money. He wanted to have a clinic in his own community. For those who are from Nigeria, you may know it. The hospital is in Ikire or something. The hospital is just across the express. So the person did not consult with the community members. What the person did was he cited this very huge edifice across a express. So what happened was when the community member tried to access this state-of-the-art clinic, they have to cross an express. So in the process, somebody who is going for headache treatment or malaria treatment tries to cross the express, gets killed by a bike or a car. So eventually people were dying more in trying to cross over to access service than the ailment they were trying to treat. So people abandoned the whole idea of using their facility. And what happened? 2 or 3 years down the line, the old facility began to be looted. People were picking, and if you go there now, it's no longer thing. But this type of error will have been corrected if the person engaged the community at the level of the design, or even proposing to site or develop that hospital. They could have maybe chosen a central area within the community that would be accessible, that even if a pregnant woman needs to go into labor midnight, they can easily reach out to them. So the participatory rapid appraisal provides this opportunity to engage with the community members to be able to do this. I've talked about the quantitative data and the sources. I've also talked about the qualitative data and the sources. So what is important now is to, what is important to do next is to be able to synthesize all the data that you have gathered. The next step is to synthesize data on nutrition status that you've gathered. So now, most likely you have gathered anthropometric data like you identified in the beginning. You want to start to synthesize that and to start also to make decision at this stage. So if you look at the nutrition status, maybe stunting or wasting, and maybe the stunting figure is 40%, then you want to use cutoff like WHO cutoff to determine, is this a significant public health problem that I should be looking at? Is this a thing I can maybe ignore to focus on more important problems? Also, you may want to synthesize data on IYCF practices. For instance, the rule of thumb would be that suboptimal practice would be any practice less than 80%. So if I look at rate of exclusive breastfeeding, and exclusive breastfeeding rates, which I believe for most African countries would be the case, is about, for Nigeria, I know is about 27%, if I'm correct. So you want to then decide within your team, is breastfeeding promotion what part of the intervention we want to prioritize in this community or the target geography you are working with. You also want to synthesize the data you may have collected on maternal nutrition. What is the rate of low birth weight? What are the data also on the micronutrient status of children? What is vitamin A deficiency among children like? What is iron deficiency among school-going children like? And some of this information that you may have collected through your quantitative data gathering at the quantitative data gathering stage. You also want to synthesize data on underlying disease burden, and typical example of those type that will be of interest to nutrition. You want to see what is the diarrhea prevalence like, what is the prevalence of acute respiratory infection, what is the malaria prevalence, tuberculosis and HIV prevalence in the community. Oh, sorry, this is a bit blurry slide, but it shows the WHO categorization of public health significance. So for stunting, for instance, if it's less than 20%, it's a low public health significance issue. If it's between 20 to 29%, it should be a medium public health significance, medium public health significance. And if it's about 30 to 39% burden, so it will be a high public health. So for countries that have stunting rates of 40%, definitely intervention to address stunting should be prioritized in those settings. So everything I've said up to this point has to do with step one, which is identifying the nutrition problem, trying to define the nutrition problem and what should constitute the priority of the program that you want to design. The next step is to determine the initial program goals and objectives. So it's possible you have identified 100 problems, nutrition problem that needs to be attended to urgently. But the reality is you will hardly have funding to address, 100 nutrition problems, right? So you really have to prioritize. And one of the output from stage 1 that we said is to be able to come up with like a shopping list, if I can call it like that, of the priority intervention you are trying to look at. So you, based on this finding in step 1, you now want to determine the initial program goals and objectives based on your findings. So let me use okay, I'll use a general example, and I'll also try to use Development Nutrition Academy as an example. So let's say now that you found that after doing your infant and young child feeding, you found that breastfeeding rate is low, or people are not practicing early initiation of breastfeeding. You also find out that the stunting rate is high. You find out that people are not doing appropriate complementary feeding. And all of these are issues that we know may impact on child mortality if their nutrition in the first 1,000 days of life is not adequately catered for. So you want to define what program goals should you then target in this regard. You also want to define what objectives should go with this goal that you're trying to achieve. Also, at this stage, you want to identify information of funding. I think I mentioned funding availability, how whatever intervention you prioritize. It may look good to say, I have a goal of feed every children in Ghana, for instance. It's a very laudable idea, very ambitious, but the reality is it visible for governments or a single individual to feed everyone in Ghana? Maybe for one day, yes, but sustainably for a period of 6 months, that will be a huge investment. So you want to know what funding information is available, which donor is working in this area, who may be interested in committing resources into this program goals, and how can I reach out to them? Do they have this current funding? Is it slated for the following year, or has their own funding in relation to the mandate also ended? Sorry. You also want to, like I mentioned, assess the donor interest to see whether this will be a potential. Some donor may not even have the funding to give you, but they may be able to provide technical expertise on how you go about. They may have resources you can already leverage on. Maybe they were working in this particular health facility or this particular community. They have been able to broker engagements with the stakeholder in the community that you can leverage on. That can also be a good resource to consider at this design stage. You also want to determine the organization strength. So within if it's a public health system, for those working in the government, what resources do government have and are able to commit to this idea? Also, if it's a maybe NGO or other international development organization, you want to know what resources are available. Is it even within the organization mandate? Is this what my organization will support? And so at this stage, the output is usually an initial program goal and objective. Okay, so just to give a quick definition to differentiate. So when we say goal, what are we talking about? When we say the objective and all that. So in determining your initial program goal, you have to define the goal, like I said. And for you to be able to frame your goal, these are some of the considerations. Goals are usually the big picture for a program. It is the ultimate ambition that your program seeks to achieve. So these are the big picture for the program, and the goal is often, goals are often long-term, and typically they are not what you can measure in the context of the program. So I may say the goal is to reduce child mortality or to reduce stunting in Cameroon, for instance, or in a geographical, I don't know Cameroon well, maybe in a geographical region or even in a community in Cameroon. But the challenge with this is that it goes beyond your program context. So no matter what you do, their goal has other issues or program contributing to it. So even if I say people should breastfeed exclusively, I did a fantastic SBCC, people are now practicing breastfeeding. If there is no food in the community, for instance, it may not make a lot of impact. Or if the care practices or hygiene practices of the people are not optimal, it may also affect whether or not there's reduction in stunting or whether or not there's reduction in mortality. So usually you cannot promise your donor or a funder based on, oh, I'm tracking this result by the people write proposal or project proposal that reads, oh, we'll have reduced stunting by the year 2023, for instance. And you are like, really? You want to reduce stunting with, say, $500,000 or of intervention? It just it just won't happen. It has not happened in the last 2 decades, so there's no point. But it's really the ultimate bigger picture that you are trying to contribute to, recognizing that other stakeholders are also contributing to that. You also want to then frame what is your strategic objective. And usually this is a statement of what the program plans to achieve. It is measured, this particular one is measured within the lifespan of the project. So whatever you are framing at this level, you want to be sure is what you can achieve in the lifespan of the project. You also want to define intermediate results. And these are the outcomes that are necessary to achieve the objective you may have set out. And you also want to develop your result framework. So for instance, let me use Development Nutrition Academy as an example. So I can say my goal is, let's say DNA's goal at the end of, by 2025, for instance, or maybe 2030, there will be 100 competent cohort members of DNA well placed in or contributing to scaling up nutrition. Yes, contributing to scaling up nutrition. You see, a lot of people also contribute to scaling up nutrition. So you cannot say if nutrition is sufficiently scaled up, it's now because, oh, DNA has done this fantastic job of building the competence of people. But rather, it's an ambition to say, in my results pathway, I could say, working with a lot of an assumption to say, if people are trained, they have the capacity to effectively design programs like we are going through, they are now able to design program that will contribute to scaling up nutrition. But I can't measure that element of scaling up nutrition within the lifespan of this project. Okay, but then my strategic objective can now be to ensure that in the next 5 years, maybe by 2025, there are at least 100 public health nutrition workforce in Africa who are well placed in the development sector. Yes, that you can follow up that cohort and begin to track, where are people placed, where were they working before, where are they now working. So this is a strategic objective that can be measured directly within the lifespan of this project. You also want to determine intermediate results. So what are the outcomes that are necessary to achieve these 100 workforce who are now able to contribute to scaling up nutrition? Then I can have elements like, complete like 4 cohorts or 5 cohorts of capacity development for nutrition workforce completed by 2023. I can have things like 50% of interns are placed by so period. So these are the kind of things. So you have to then go through the cycle of saying, oh, really, even if this happens on this assumption, so what then leads to, how will this link to achieving objectives? So these are the kind of things that goes on in project design that will determine whether or not there is possibility of being able to achieve the results. Then you begin to develop your result framework, which of course we'll talk more when we get to this section of logic framework. So the step 3 is to determine initial program goals. Part of that is also to assess national policies availability, access, and uptake of relevant service. So sorry, there's probably a mistake with this slide or something. So to recap everything I've said anyway, since we said step 1 is to gather information on the nutrition situation. Step 2 is to determine initial program goals and objective. Step 3, yes, is to review available services, be it nutrition, health, agriculture, social protection, like we said. So after you have now done all of this, your program design, you have to see what services are even being available and currently being implemented. So perhaps people are already doing exclusive breastfeeding promotion, or people are already doing agri-sector nutrition sensitive mainstreaming. What are these programs like? You have to assess which of the program has worked, which of the program did not work. Okay, which of the program worked, which of the program did not work, and all of that. So because this information is also important for you not to make the mistake that other people may have made in their initial design. Okay. Again, in case I go off, we'll try and see whether we get a touch chance to do that. So that's step 1 up to 3. We have 3 other steps, which is then this preliminary design. You now have to go real deep into the design, and you have to do that by selecting potential preventive approaches, or you select whether you want to use a recuperative approach. Again, you have to now finalize your program design. You assess the initial goals and objective, you cost the selected program option, you review program consideration and assumption. Like I said, you have to also put assumption along the way, what will happen next if this happens, what happens. We'll go more into this when we get to the log frame development. Then you finalize this project design. Another thing that often people miss out is the issue of you have to review the design with selected stakeholder. Like I cited an example of 2 communities earlier, where you may think this will work in your office, you're designing it, and by the time you get into the field, people who are into the community, then you realize that it will not work, at least by their own observation, it won't work that particular way. So again, this is the summary of the last 6 steps. So in total, we have like 6 steps. We talked about the earliest 3, then the last 3 is preliminary program design, finalize your program design, and review the design with selected stakeholder. So I'd like to say thank you.